before going before going into the session as such, I would like how many of you were able to go through the communication sessions in the self-learning module? All of you went through?
Yes, sir.
Okay. So was there any challenging topic specifically, or is there anything you want to ask?
Hello, sir. I'm audible.
Yes, yes, you are audible.
Okay. The whatever modules we saw,
Mm,
it was more of Western oriented thing. Like people express a lot,
mm,
and our people, our Indian people, they do not express much in a way.
okay.
They express only like the outstanding symptoms. So
Mm,
emotional symptoms usually they don't express much, I feel. So how do we communicate with them?
okay. Yeah, that's good question. Um, so, may I ask you which specialty are you working?
Sir, I am a anesthesiologist. I am practicing cardiac anesthesia as well as I am now practicing like starting to going to start palliative care also.
Okay. Yeah. So this is one area, the exploring the psychosocial and the spiritual part is something which actually we were not taught in that way. We usually take history when we do MBBS or specialty or super specialty, but that also usually concentrated mostly on the physical problems. So we are not taught to do that. So I think that is a important issue that I see. So that's why um, in palliative care we do give a lot of stress on proper communication. So if you ask anybody who's working in palliative care, so they find it or uh, as you have gone through all the modules, you might have understood that palliative care, it is not only looking at the physical problem but also the psychosocial and the spiritual aspects. So it's our duty to explore and find out that aspect. So I'm sure the communication skills will help you to explore that area. And this is what we usually do in our unit. Uh, each one of us, we have an interdisciplinary team, including doctors, nurses, social workers, that is medical social worker, psychologist, physiotherapist, and various other doctors. So all of us would try to explore the psychosocial and spiritual area in addition to the physical problems. So if uh, if you are more or if you can understand more of how to communicate, I am sure you would be able to do that. So let me share a video with you uh, about communication. I would request all of you to watch this video, and please give your observations after watching this video. Okay. Can any of can any of you tell me your opinion about this?
Hello.
Yes, Dr. Swati or Dr. Sajida, please speaking.
very non-empathetic manner.
Okay. So
You know,
yeah.
not
Continue.
like, even though the patient is telling he's having pain, he's not. She is telling, okay, you take some tablets which they will be already taking, and so like, you should. She's not probing into what are the reasons for pain, or what is the severity of pain, and not consoling. Nothing is there. Then she is playing the blame game. You are it is because you smoked. All those matters need not be told now. It has already been done, so what is the use now telling, like, because it was because you have smoked all these years. Now there is no use of telling at this point of time.
Okay. Yeah, very good. Anybody want to add? Yeah, I can see there are some comments. Yeah, Dr. Priya.
The body language of the ASHA worker, and the fact the mobile keeps ringing. She walks in talking on the mobile. She doesn't take a seat. It's not as if she's making any time for the patient, though she's doing a visit.
Yeah.
I think the patient's really desperate. And he mentioned several things, and she, as the other doctor just said, she doesn't explore it in any way. In the tail end, he mentions a nausea, and that he doesn't have much of an appetite, and she says that she's going to address that to the doctor and get back to him.
Yeah.
Very abrupt, very
yeah. Okay. Yeah, very good. Dr. Muhammad Rami says there is no empathy at all.
In short,
yeah.
Can I speak, sir?
Yes, Dr. Abraham.
Yes, sir. This is
Dr.
actually
Satyanarayan.
quite a realistic looking scenario. Actually, we've seen patients like this, and we've seen people being managed like this quite often. It's a realistic scenario that you put up over here, sir.
Okay. Yeah.
That the patient is not in control. It's the doctor who is in control here of the situation. She's the one who's giving instructions without actually addressing the problems of the patient, and making the patient feel comfortable.
Okay.
I would say that instead of asking the patient how he is and asking open-ended questions to him, she is just making assumption, and she's going about on it like, okay, you're not eating, the wife must have not fed him, and making assumption and passing statements which is not appropriate.
Yeah, she's blaming the wife, isn't it?
Yes.
Yeah. So anybody else?
I want to add, sir.
Yes, Dr. Satyanarayan.
In short, total pain concept is missing here, sir. So that whatever worker, she's just addressing that as some kind of duty visit, and she's not addressing the patient.
Yeah. Yeah. Okay. Anybody else? Okay.
At one point, she also dismissed the pain of the patient, saying that it is expected, and instead went on a tirade that she herself is also feeling pain nowadays. It is kind of a dismissive attitude.
Yeah, it is about sleep, isn't it? Nowadays, I am unable to sleep. That's what the patient says. Then ASHA worker says, because a lot of heat outside, I am unable to sleep. Yeah. So just want to show you what were the problems here. Please look at this. Something which we saw at the beginning of the video. Asha worker says, no, I am very busy. I am unable to sit down. So if somebody is unable to sit down, that itself gives the message that I am very busy. So whenever you communicate, it would be good to sit with the patient so that the communication will be lot more efficient. So there are communication research in which the patient was asked to listen to the doctor in various positions. Patient is sitting, then doctor is also sitting. That is one situation. Another situation, patient is sitting, doctor is standing and talking. And when they compared, the patient felt that when the doctor sat down and spoke, that the patient felt more satisfaction, and patient also felt that the doctor spoke for more time, even though in both position the doctor spoke for the same time. So it is important for us to understand that whenever we see the patient, both should be at the same level. And I know many of you might be working in very busy OPDs and may not be able to speak much, but maybe it would be very good if you can say, "Good morning, please sit down." So that would give the patient some relief by this gesture itself. And never blame the patient. So this patient already has CA lung, and here we are again blaming him, saying that if you had not smoked these days, this would not have happened. Actually, this is not required, isn't it? You can say if the malignancy is curable, or if we are hoping for some prolongation of his life, then we can tell him that we have to avoid the smoking. So otherwise, talking like blaming the patient should be avoided. And Asha worker, which we already talked about the sleep.
I'm not able to sleep these.
All of you picked up many points from this communication video. And it is usual that we cannot avoid the mobile phone, because that's the usual medium of communication. Dr. Abraham has, what is that? Caregiver not being willing to sit implies to the patient. Patient that he is not important enough to spend sufficient time with may cause the patient to be less willing to take the caregiver's advice, and may cause the patient to feel the caregiver doesn't care his care. Okay. So here the person who came is Asha worker, and the other one who is sitting with the patient is his wife. Okay. So actually, we should not blame the patient. This will not do. You have to eat something. That is ordering. But actually, all of us would like to eat. There should be some reason behind this. It is important for us to find out why the patient is not eating. Then we have to address. That's what we have to do. So this communication video is a video which says you that this should not be the way of communicating, or this is an example of bad communication. Okay. I will show you another video of the same scenario. So how do you see this video?
The patient had some relief of the symptoms just by the interaction with the doctor, but with the ASHA worker.
Yeah.
Because they spent time, they were empathetic. The patient also, in addition to the medication, just the psychological aspect that somebody cares about him, that somebody is paying attention to his symptoms, seem to have given them some hope also, and also helped some of his psychological symptoms compared to the earlier scenario.
Okay. Yeah. Thank you, Dr. Abraham. So if we create a rapport with the patient, then they will automatically talk about their problems. So we have to listen more. And then the patient would be able to tell us what the problems they are facing. So here the patient started with pain, but then when the patient felt that, okay, this a person, the ASHA worker, she is listening to me. The patient is then came up with many other things. Yeah, importance of non-verbal communication is very well demonstrated. Yes. Okay, anybody else?
Sir, I think I'm Dr. Annie here.
Yeah.
I think this approach by the ASHA worker in the second video that gives a lot of encouragement to the patient, relative, and they get to understand how better to approach the problem. So the problem remains the same. There's a better solution to it.
Yeah. Yeah. Thank you. And I want you to understand that empathy is something which we have to practice whenever in during communication. So, can anybody tell me how to make an empathizing statement or empathetic statement when patient is emotional? This is a very powerful tool. Suppose the patient is in pain and he is crying. What would you tell this patient as an empathetic statement? What is an empathetic statement?
Sir, empathy will be trying to make the other person understand that they are able to comprehend the other person's anxiety and pain. So I feel that telling the patient, I'm able to understand your pain and we will look into it and let us see how we can go about giving you better pain management.
Okay, and the first part is absolutely right. We are making sure that the other person understands. Sorry, there was some disturbance. So, by telling an empathetic statement, we are actually making understand the patient that we care for them. Okay, so what would be an empathetic statement if the patient is in severe pain and is crying? Anybody? Actual sentence, what would you tell this patient? So you can see on the screen expressing empathy. You look so distressed. Huh? Or for the situation which I have told you, a patient is in pain and crying. You can tell him that, your pain is so severe, isn't it? Something like that, so that uh, we cannot actually understand what he is going through, but we can assume what he is going through. That's what we can do, because we are not actually experiencing the suffering. We can only guess. So that's why actually we should not tell I understand. I can only guess. So how to make an empathetic statement is you connect the emotion with the issue. So what is the emotion? Patient is crying. And why patient is crying? Because he is in pain. So you might tell that, okay, uh, your pain is so severe that, or you are so much distressed, and I can see that tears are coming. So that gives the patient an insight that, okay, this person who is sitting with me, he is understanding me. That's what the message that can be given through an empathic or empathetic statement. Okay, so empathic or empathetic statement is something which you need to use regularly in your communication. Okay, and now, so can somebody tell me what are the don'ts in communication? What are the things you should not do during communication? Anybody?
We should not use medical language. Try to talk in layman, simple language without using many medical terminologies.
Yeah. So avoid medical jargons. Yeah, that's very important, because the patient will not understand our language. We all are medical people, and we would have a tendency to talk in medical language. So we have to avoid that. Yeah, very good.
We should
Avo-
never assume,
yes.
and
Yeah.
we should listen more and talk less.
Yeah. That's also very important. Assuming is something which we never should do. Uh, and this is what usually happens in our practice. If somebody is crying, what would we do usually? We would go and tell that patient, don't worry, don't worry. Huh? So everything would be all right. So why this is the way how we actually reassure the people, but that's not right, because we don't know why that patient is crying. So we have to understand why the patient is crying. So here we assumed that this patient has some problem, and that's why this patient is crying, and that's why we are reassuring. So never uh, assume, and we have to actually explore the reason why they are doing, or why they are crying, why they are telling, etc. So never assume. That's very important.
So maintain a positive and a reassuring tone,
Yeah.
and also we need to respect the dignity of the patient, autonomy
Yeah.
throughout the communication.
Yeah. So we are talking about do nots in communication. What are the things we should not do?
We should not give false assurances.
Yeah, false or
motive.
premature reassurance should be avoided. We should actually give realistic assurance. So that's why we need to understand what the problem of the patient, and after understanding the problems or issues, then only we can give realistic hope to the patient. Suppose the patient is in stage 4 malignancy, and we think that this patient is going to live only for uh, a few weeks. We should not tell that patient that, okay, you will be all right after some time. It should not be. Okay. So don't give false assurance or premature reassurance. Yes.
Don't interrupt when the patient is speaking, because there's this concept of a golden minute, that let them speak at least for 1 minute. Most of the people will they'll be able to complete whatever they are saying within a minute. So the doctors generally have a very short attention span, and they tend to interrupt the patients within 18 to 20 seconds. So just listening to them is a big relief for them, that someone is listening.
Yes. This is a very important point. Don't interrupt the patient, because if you interrupt, then the patient would take more time to talk to you. But if you don't interrupt, then the patient is going to take less time. And each one of us has to introspect what we are doing. Are we giving enough time for the patient to talk? Are we interrupting frequently? And it has been researched and found out that mostly doctors interrupt the patient by 16th second. So all of us has to think about it. Yeah, that's a very important point. Yeah, anything else? So there are many things which we should not do. We should not blame the patient. We should not argue with the patient. Suppose a patient who has severe pain came to your OPD while you finish your OPD and you want to go home. You have actually finished, and by that time the patient is coming to your OPD. Then you have again gone to see the patient. He got admitted. Next day, actually you had to give a morphine trial, and morphine actually gave the patient. You told the patient, okay, told the nurse or junior doctor to give the morphine trial. You just saw the patient and gave the necessary instruction and went home. Next day, when you were in rounds, you saw this patient. What question would you ask this patient? Anybody?
How are you feeling today?
Yeah. Any other response? What do you usually ask the patients?
Is the pain controlled?
Sorry?
Is the pain fully controlled?
Sorry, Dr. Abraham, I didn't get you properly.
So has the symptoms been totally controlled?
Okay, okay. Has the symptom been
If he have
totally...
his relief of symptoms.
Yeah. Okay, thank you. Anybody else? So, I would give you a response. Your pain is reduced, isn't it? What do you think? How is this response? Is it good, bad, or neutral?
Bad.
Bad. Why? Why it is bad?
We are making an assumption. It is കുറഞ്ഞു അല്ലേ എന്നാണ് ചോദിക്കുന്നത്. എങ്ങനെ ഉണ്ടെന്നല്ലേ ചോദിക്കണ്ടേ?
Yeah, yeah. Very good, Sajita. So, actually, the statement or the question which I asked is known as leading question. Leading. So, what is leading here? What we want to know? Actually, we want to reduce the pain of the patient, isn't it? So, and we also want to hear that, okay, my pain is reduced. That's what we want to hear. So, in order to hear that response, we are making a question and asking the patient. So, your pain is reduced, isn't it? So, this is known as leading question. So, never ask questions which leads the patients to the answer. Actually, we want to hear my pain is reduced. So, in order to hear that response, we are making this question. So, that's known as leading questions. So, you are the doctor who actually, after finishing the OPD, has to wait for some time for this patient. And this patient also knows that you are close to your OPD, but you came to see the patient. And next day, when you ask this question, it would be very difficult for the patient to tell that no, my pain has not reduced. So avoid leading questions. Okay, never ask leading questions. Okay, so some of the important don'ts or do nots in communication: never assume, avoid medical jargons, never ask leading questions, avoid premature or false reassurance. And we know that we should not blame the patient. Uh, we should we should not be judgmental. So there are many things which we usually get it correct, but the assuming part or leading question, which many people practice without knowing that this should not be done. Okay. Now, can we talk about communicating bad news? How many of you have communicated a bad news to a patient? Anybody?
Yes, sir. I work in radiation oncology, so we have a lot of patients to whom we are the people who have to break the bad news. The surgeons will take the biopsy and then they'll send the patient to us to inform about the diagnosis.
Okay. So how did you find it? Even though it's your usual practice.
The thing that they say about the stages of grief, actually, that is something that we commonly see in the OPD. Patients may begin by not accepting the diagnosis. They may refuse to believe, they may get angry. The anger, denial, all those stages are something that you see. So we try to break the news gently. The patient comes to us initially. We tell them that there is a lump, it's a mass, it is suspicious. We need to evaluate it further. Then we'll send them to the surgeon. The surgeon will take the biopsy. They'll come back to us and we'll say the biopsy has been taken. Most of it is something serious. You'll see it when the report comes. We reassure the patient that whatever happens, it is not the end of the world. It's not that nothing can be done. It may be the lump is not malignant also, we will see. And when the report comes, we'll see what it is. If it turns out to be a malignancy, we will tell them, okay, this has come, but this is not the end of the line. We'll just do some investigations. We'll find out what the stage is, and we'll see what we'll be able to do to help you. So, we'll break it in stages. We don't shock them with the diagnosis. Cancer ho gaya, marne wale. We don't say anything like that. We gradually introduce them to the idea that they have something serious. It may be cancer. It is cancer, but it may not be for the stage we need to see. It is stage 1. We can treat it easily. Stage 2, it's a more aggressive treatment, but it can still be treated. Stage 3, it is difficult to treat, but there is still a good chance that you may be cured. Stage 4, cure is not possible, but we will be able to do something to help you. We are not going to leave you as such. We will try to help control your symptoms. We will try to give you as much relief as possible, and we'll try to enrich the time that you have left and make it as comfortable for you as possible.
Yeah.
So we try to do it gently.
Okay. Thank you, Dr. Abraham. Do you usually communicate this news to the patient or to the caregiver?
We, generally speaking, mostly we do it to both, but sometimes only to the caregiver. Depends on what the patient is willing to accept. Sometimes the patient says कि मेरे को मत बता दो, मेरे साथ वाली को बता दो, उनको सब कुछ पता होगा. they will see and all that. So the patient doesn't want to know the diagnosis, we inform it to the caregivers. If the patient asks, we definitely tell them. We do not withhold the information from the patient when they ask.
Okay, I can see that Dr. Ramesh says it is usually this bad news is communicated to the caregiver, usually. So I would like all of you to tell me that how many of you think we should give this not only cancer about any serious news to the patient directly? Should we communicate the serious news to the patient?
An adult patient who is of lucid mind, I believe that we should communicate it to the patient along with the attenders if the
Okay.
patient is willing for that. I have a very strong opinion about this.
Okay, Dr. Nitish, thank you.
Basically, I feel that we have to ask the patient whether he would, he agrees to know the information for himself, and if he says yes, then it is necessary to divulge the information. Similar question should be asked to the patient's relatives as well, whether they are ready to, whether they will be able to take the bad news or not. I mean, the news or the information, and then it can be given to them.
Yeah. Okay. Thank you, Dr. Shraddha.
Medical legally, we are obligated to inform the patient if the patient wants to know. Informing the caregivers also, I think medical legally it is as per the patient's purview. If the patient is willing to share the details of the letter, then we are allowed to share. But otherwise, ideally, we are not supposed to only communicate with the caregivers and ignore the patient.
Okay.
Sir,
Yeah.
regarding children, we have had difficulties. Parents will say, "Don't tell them," but we know that the child already knows better. But because the parents are not allowing us to tell the children about their disease, it is difficult for us to tell them.
Okay. Are you a pediatrician, Dr.
Yes.
Shraddha?
Yes, sir.
Okay. Yeah. So, if you look at it ethically, what should be done?
So we should definitely tell the patient after obtaining due consent of the patient that if he is willing to hear the news. So in our palliative setup, we do take the consent and let the patient know, because later on there'll be collision between the family member and the patient, and it's very difficult to go past that. So we are facing issues because of that, and yeah, I strongly believe patient should know.
Okay. But what do you think the reality is?
The reality is that the patients don't want to know, and the family is also not ready to accept the fact that the patient is in a terminal stage, and it's not how it is in the books. So it's very different. It's very difficult to communicate as well.
Okay. There was a study conducted.
Can I make a
Yes,
comment,
Dr.
sir? So in the Indian scenario, especially, there are a lot of patients for whom they will not be the people who make the primary decisions about their healthcare. The wife will say, "Ki mere husband ko bata do," or they'll say, "Papa ko bata do, bhaiya ko bata do, elder brother ko bata do." They will make the decision. Mere ko kuch nahi batana hai. So that is also something that is seen, I think, more in the Indian scenario than in the Western world.
Yeah. So there was a study conducted by Tata Memorial Cancer Center among caregivers of patients with malignancy, and there were many questions, but the important questions to the caregivers were, would they be willing to to communicate the bad news by the doctor to the patient? Would they allow the doctor to communicate the bad news to the patients? And most of them, I think about 70% told it is not necessary. But when they were asked whether would you like to hear the bad news when you becomes a patient, then most of them want to know that. So there were many questions, but so this is the contradiction. When we one of our family member becomes a patient, we don't want the doctor to communicate the bad news to the patient. But when we become the patient, we say we want to know. Okay. So this is the in most of the Asian countries, I think this problem happens. The relatives would be the prime people, or they will talk to the doctor directly and will tell them, please don't talk to the patient, and whatever you want to tell, please talk to me. So from the ethical point of view, autonomy is the most important ethical principle. So if you respect autonomy, you should give the information to the patient. Then only you are respecting the autonomy of the patient. And if you look at the West, in UK or USA, actually we should talk to the patient only, not to the caregiver. If we give some information to the caregivers without the consent of the patient, they can actually sue us. So this is the difference between Western culture and Indian culture. In India, there is the caregivers. They actually take the patient to the doctor. They will be there throughout the treatment till the end of the patient. So they also have some autonomy. So patient autonomy is very important, but we have to also consider the autonomy of the caregiver. So that's why there is some dilemma occurs, not dilemma, some frictions occurs between the patient's autonomy and caregiver's autonomy. But anyway, patient has the right to know the diagnosis or the information about his or her diagnosis or prognosis or any other news. But it is not their duty to know. So if the patient says, I don't want to know, then we can actually, what would you tell? If suppose a patient tell you that, okay, I don't want to know about my diagnosis or prognosis, what would you tell this patient? So we say that it is the right of the patient to know that information. Yes. Anybody?
I would tell the patient that for compliance with further plan of treatment, somebody who can take decision, whether the patient themselves or somebody else, will have to know the details. They cannot deny that we do not want to know anything.
Okay, yeah, that's very good. Anybody else would add anything more to this, what Dr. Nidesh said us?
Sir, I feel that patients should be told, and it can be a phased out method, not giving it an immediate, everything together. They should be slowly, the news should be given to them. The issue arises when patient's treatment is prolonged, like in cancer, etc. If we are trying to withhold, it's not possible to withhold all this without the patient getting to know some amount. And half knowledge becomes very, very ineffective in their treatment. So if they realize that the rest of the team, the relatives or caregivers are very supportive, I think the patient also takes it in their stride. they are able to face it better.
I agree that, but what can we do if a patient tells you that, no, doctor, please, I don't want to hear this. You can tell this news to my son who is with me. Please talk to him. I don't want to hear.
That is the problem in India, especially compared to a Western country where they'll come with all the facts and figures and Google up everything regarding the disease and they'll come alone to the doctor. But here, as you said, they will pass the buck to the relative or the caregiver. And it's a very difficult situation for the doctor to handle. Actually, when such a person is not wanting to know.
Okay, but what we have to understand is, we have to, as I told earlier, it is the right of the patient to know, but it is not the duty of the patient to know. Okay, so here this patient is telling that, okay, I don't want to know about this. We have to respect that. That's what autonomy is. But we have to also tell him that, okay, I understand that as of now you don't want to know about the disease, but if you feel later that I want to know, please come and talk to me. But for the time being, I will talk to your son. So this is what we have to do. We should not force the information on the patient because he has already exercised his autonomy. He is of the opinion that I don't want to know as of now. So we have to respect that. Okay. Okay, I will show you another video.
So evaluating something that you've generated, performing various tests.
Okay. So any of you have any comments about this? Anybody?
Sir, the doctor didn't say anything about the diagnosis, but from the way he was talking and suggesting moving the wedding forward, it sounds like it was not a very good prognosis. Generally, for cancer, you like the 5-year survival data is something that you would be able to say, you're this stage, the median survival, 5-year survival is this much percent. But we are able to give a rough idea when the patient asks. So in this case, I think he could have been a bit more forthcoming with that. And because the patient was asking about details that you'll be able to plan further. This is actually information that the patient sort of needs to know in order to make plans for. If he was empathetic, I agree. He was caring, he listened to our concerns and all. But I think that he should be more forthcoming with the information as well, so that the patient can plan for the future properly.
Okay, so I just want to ask you, the survival data, it should be individualized, isn't it? Not the one which we get from the studies. It is not individualized. Am I right?
So every patient is different. Like some patients may live for longer, but you can give an approximate idea ki, in this case, your the average survival is this much. We are going to give you treatment. Depending on your response to treatment, it can be more. Like for RCC, for example, before all these newer drugs came out, before the TKIs came up, the survival used to be much less. But now you're getting patients even with metastatic RCC who have good survival.
Yeah.
Sir,
There
I
is
think discussing the best case scenario and the worst case scenario in such a situation
is the most appropriate thing so that the patient can have a fair idea. And obviously, we have to tell them that this is an average kind of a reading. It is not a fixed thing about, that the survival time for a patient with a specific cancer.
Yeah.
So,
Thank you, Dr. Shraddha. Anybody else? So I think there is no absolutely wrong or right answers here because we will not be able to predict. So as Dr. Abraham told, there are some tools available, 5-year survival, or maybe there are even more other tools which predicts 30-day survival or 21-day survival, etc. But I think what's most important is why the patient is asking that question is what is most important, because then we can understand. Here it is about a patient's marriage, and if the doctor think that okay, this patient will not have much time, then we can ask them, okay, if possible, do it as early as possible, possibly in this week or something like that. So we cannot suppose if you give okay, whenever we say the survival chances or 5-year survival is 50% or something like that, the patient may not understand it correctly, and what they usually do is they will mark it in calendar, or the relatives, usually what relatives tell us that okay, that doctor told me that we have only 2 months to live, but now it's 3 months, doctor. So this is how they actually interpret it. So it would be better not to give time frames as such, but uh, an idea about what's going to happen is also important. But the prediction of survival becomes more correct when it comes to a few days to live. So there is no absolute wrong or right answers, I believe. But here we are looking at the way that he has communicated the news to her, news to this patient. So there are many ways by which you can actually communicate the bad news to the patient. And one of the most common protocol is spikes protocol. So what is spikes? Anybody? Spikes protocol? What is S?
Setting.
Setting.
Yeah, setting. So setting, what all should we be careful?
We should make the patient sit and away from all busy areas, and we should be the patient also should be comfortable at that time.
Yeah.
Patient or the caregiver, not when the patient is in pain or when the bystander is busy.
Yeah, we should also have time, isn't it? We should be able to talk to the patient. So if you think that, okay, I have 15 minutes to communicate bad news, so I will do it during this time, that would not be good. Okay, yeah, setting. Yeah, next one is
Perception.
perception. So what would you do?
What do you know about the disease? What does the patient already know?
Okay, so actually you need not ask the direct question. So how do you do it otherwise? Without asking.
ಪ್ರೇಮ್ ಎರಡು ಲಾಕ್ ಮಾಡ್ದಿ ಇವು ಎರಡು ಲಾಕ್ ಮಾಡಿ
How do you do it? You need not ask direct question. What do you know about your disease? That should not be the way. That can be, but what would be a better method? Anybody?
What do you want to know?
Okay, that we have to ask in the beginning, isn't it? Do you want to know? But before that, actually you can the patient has come to you with some symptoms or something like that, and this patient might have seen many doctors and has gone to other hospitals. So you can simply ask the patient, can you tell me what happened to you? So patient will go through this history, and once the patient might tell about his symptoms, and I have taken this medication, that medication. So you can ask them, what was the reason why the doctor gave you these medications? Patient may tell you, okay, I don't know. So then you can ask them, would you like to know why these medications are taken, or why you have these symptoms? So without asking directly, you can actually ask these questions and find out what is the perception of the disease. What did that doctor tell? When he asked to take the X-ray, what did the doctor tell you? So these are the ways you can explore the perception of the patient. Okay. What is next? What is the next? Spikes? SPI?
Invitation.
Sorry?
Invitation.
Invitation. So what would you ask?
Here we would ask what do you want to know about the disease.
Yeah. Okay. Yeah. Then what is the next thing? So you can actually add a warning shot here. So what is a warning shot? Patient told you, yes, I want to know. So what would be a warning shot?
I'm sorry that the information I have to give you is not a very good news. Are you sure you want to know?
Okay, something like that. So you are again confirming whether the patient want to know, even if it is something serious or if it is something bad. Do you want to hear even if it is something serious? So this spanning shot actually set the scene to a serious serious mode. Now the patient can think, okay, should I hear if it is going to be serious? Should I know that, or shall I ask my son to hear that? So patient, we are giving the patient a chance to think about it. Okay. So after giving warning shot, then we have to give the case for knowledge sharing. So you have to give the knowledge, that is the information with you in small chunks. So when you give the information, it should be very simple. It should be in simple sentence and simple language. Don't say a sentence which has a length of 10 kilometers. So just give a few words. It should be clear. And then you have to stop. So So this is the time, pausing is the time in which the patient can actually think about what you have told, and you are also giving a chance for the patient to ask you question. Okay, so pause is very important, not only in communicating bad news, but in general communication, pause is very important. So, Dr. Abraham previously talked about how to give the information. So maybe you can tell the story of the patient in a narrative mode to the patient itself. So you can start with the patient. The patient told you that, okay, I have gone to this doctor, that doctor, have taken X-ray and CT scan. So you can ask the patient, why the doctor took this CT scan, and what was the result? What did you tell you? Patient may tell you, oh no, I don't know. So so you can, if the patient don't know, then you can tell, okay, the doctor asked you to take the X-ray, and in that X-ray there was some shadow in the X-ray, and stop it there. Patient might ask, okay, what is the shadow? Or if the patient is interested by body language, or if he is asking, you can go and tell that, okay, to understand better about this shadow, you underwent the CT scan. And in the CT scan, it showed that there is a mass. So at each and every point, you have to pause and look for patient's response. And at last, you can go and tell that from mass to, you can say, that's why they took out some part of this mass and examined it under the microscope, which finally came out to be a tumor. And then you can tell that, okay, tumor is, you can actually explore the insight of the patient. You can ask, do you know what is tumor? Patient might tell, okay, I know, I don't know. So you can tell that it's like cancer, and you finally tell cancer. So some people tell this is called euphemisms, but there are various ways by which people communicate the bad news. So some people directly tell it's cancer, but some people will go through this way. Okay. So after sharing the news, what do you expect from the patient? What's your experience? Dr. Abraham, what's your experience?
Yeah, it is not common that we have a patient that comes with a very clear set of circumstances like that. Generally, the patient would either have some idea about the diagnosis, or uh, generally, mostly a patient will know. They may pretend that they do not know for the sake of their relatives. The relatives may pretend that they do not know for the sake of the patient. But since in our department, we are like referral. Generally, we will not be the first point of contact. So in our circumstances, mostly the patient has an idea that there is something that is wrong. And when they come to our department, they're mostly sure that the diagnosis is cancer. They have a very high index of suspicion.
Okay. So what does others think? After knowing the diagnosis, what would be the response of the patient? Anybody has experience with this? Communicating bad news and anybody?
In my experience, patients respond differently. Some patients, they take it in their stride. They're very cheerful. As the treatment goes on, also they're very cheerful, and generally they tend to handle the symptoms of pain and discomfort better. Those who are apprehensive, those who are worried, they tend to feel, but the pain is a subjective sensation and their threshold seems to be lower, especially for the other and treatment-related symptoms also that come. Patients who have not taken their news well tend to have more of those than patients who have taken their news well.
Okay, thank you, Dr. Abraham. Dr. Swati, you were going to talk.
As that the first response from the patient might be disbelief. So we need to give him time to process that. And slowly, maybe over a period of time, he'll accept it.
Okay. Yeah. What would be the what you told is right. Mostly the patients would be emotional, isn't it? Mostly, but I have seen some patients, or some patients have told me that, thank you, doctor, for telling me this. Now I understand how to plan my life. So it is not only about crying, it sometimes gives more insight to the patients, because many a times what happens is the caregivers would talk to the doctor, and they don't give any information to the patient. Patient doesn't understand what is happening, and actually he want to know, and that type of patient might respond like this also. So after giving the information, you have to handle the emotions with empathy, and a patient might have many questions regarding the treatment, what can be done, things like that. And we have to answer it truthfully. Then at last, we have to make or we can talk to the patient, give a summary what we have talked now, and then definitely we have to talk about the next appointment, and if possible, give a number to the patient, because what happens is, when you give this bad news, the patient will actually forget to ask many things, and whenever they go home and think about it, they will have many doubts, and that would be the time where the patient needs support mostly. And so we have to give the patient a number, and encourage them to talk to us if they have any doubts. Okay, so this is how generally it is being done, using the spikes protocol, but practically, sometimes there may be some variations in the steps. Okay. So anybody want to talk or comment anything?
Sir, sometimes when we break the bad news, and when we see their emotions, we also will get emotion.
Yeah.
Then what to do?
So actually, from a traditional point of view, we should be emotionless, or we should not be emotional, etc. But if you feel, or if you have the emotion, there is nobody obstructing us, or please express it. If you need to do that, there is no such hindrance, or don't hesitate in expressing that emotion.
So is there any level of depression that you would consider maybe sending the patient for like psychiatric help or something if the patient is very upset? Or do we continue to console the patient, or how do we manage that if the patient is very, very upset and is not, the emotions are still continuing to be disturbed?
Okay. Yeah, that's a very good question. Because it's we know that what we the news which we have given is a very serious one, and that is going to negatively affect the patient's future life. So um, it is going to definitely affect the patient. But if we see that uh, I don't have any time frame, but maybe after a few uh, days, if the patient is unable to cope up with the situation, and he is still continuing to cry, and the things which he was doing previously, he was very fond of talking, he was very fond of hearing music, very workaholic, and he is not getting involved any of these things, then probably that would be the time to get the help of a mental health person. When it,
And for
yeah.
and for patients who are already on treatment, like sometimes elderly patients, especially, they may already be on treatment for depression, some of the schizophrenia, similar problems. For those sort of patients, when we are breaking the bad news, do we need to involve the psychiatric care from that point itself, or if the patient is not coping or at that time this time, when do we need to involve?
Yeah, I think it would be better to talk to the treating psychiatrist before you talk to the patient, so that they will also feel that, okay, this doctor involved me in this care. Now, who is my patient? So I think that if possible, that would be a better solution. If the treating doctor is not, um, we are unable to communicate with him, then probably we can ask one of our colleague and go forward.
Thank you, sir.
Sir, sometimes they will get angry. Then we also if they are not understanding our viewpoints, then sometimes even we will also think they are not understanding us. Despite our best efforts, then we also will not feel like talking to them. These bystanders especially. Then what to do?
Yeah, this happens. But what we need to understand is anger is something which loses our energy. So we have to consciously make us calm. So if somebody is angry at me, I will not be angry at that person, because that will actually make up the situation worse. So don't be angry with the patient. Rather than that, you can actually uh, be there with the person and hear what he want to say. And once his anger is little bit decreased, then maybe you can actually give a empathizing statement, telling that, okay, um, you are angry because this has happened. So that person might have some relief by hearing this, and then you ask them or explore more about, can you tell me more about why you were angry? So that's the way you should go. Otherwise, if you also become angry, then that will create a law and order situation. Shall we wind up? Thank you, everybody, for actively participating.
Thank you, Dr. Sunil Kumar, for wonderful discussion.
Thank you, sir.
Thank you, sir.
Thank you, everyone, for
Thank you.
and joining the session. Thank you. Let's see in the next session. Bye.
Thank you, sir.